Hello, I'm Dr. Richard Schwartz, President of AI Medical Devices and the co-inventor of the rigid intubating fiber optic laryngoscope, or the Airway RIFL. This video will show you the proper use of the Airway RIFL, and it is essential that you view this and practice on a simulator prior to actual patient use. This will assure you your best chances of first-time success utilizing the Airway RIFL. The Airway RIFL is the most versatile airway device on the market today. In this video, you'll see the versatility of the Airway RIFL. We'll demonstrate its use as a standalone device, its use as an adjunct to standard laryngoscopy, the use of the Airway RIFL with the rifle blade guide, the use of the Airway RIFL with a patient in a cervical collar, intubation with the Airway RIFL through a variety of supraglottic devices, its utility in awake intubation, as well as its use as a lighted stylet. You'll learn the optimal setup for the Airway RIFL for the use in each of these procedures. The components of the Airway RIFL. The on-off switch is located here. Turning the base plate clockwise turns the Airway RIFL on. Notice the on-off indicator here, and the light source comes on with that. The eyepiece swivels 20 degrees in either direction to suit each individual user. The handle is squeezed, articulating the tip of the Airway RIFL. The tube stop can be set by turning the set screw and adjusting the length along the working length of the Airway RIFL. Now we're going to discuss the setup for the Airway RIFL. Setup is very quick and simple, very similar to setup of a standard endotracheal tube with a stylet. The working length is inspected for any defects and lubricated with either a silicone-based or water-based lubricant. The endotracheal tube is prepared in the usual fashion, and the Airway RIFL is inserted into the endotracheal tube. The endotracheal tube length is adjusted so the Airway RIFL ends just inside of the tip of the endotracheal tube. The light source is turned on, and the Airway RIFL endotracheal tube is articulated, light source is confirmed, and you're ready to intubate. To minimize fogging, the use of an anti-fog wipe should be considered. The anti-fog cloth is removed, and the distal tip of the scope is gently wiped with the anti-fog solution. This anti-fog solution is allowed to dry and is gently buffed with a piece of gauze. The scope is now ready to use. In patients with bloody airways or heavy secretions, in addition to conventional suctioning, the use of the oxygen insufflation attachment should be considered. The oxygen insufflation attachment is easily attached to the Airway RIFL by inserting it over the scope and seating it onto the tube stop. The endotracheal tube is then placed in the usual fashion and seated into the O2 insufflation attachment. The tube is then adjusted in the usual fashion and the oxygen tubing is attached to oxygen and run at 6 to 10 liters per minute. This will assist in clearing secretions from the airway as well as oxygenation of your patient during the endotracheal intubation. For the successful use of the Airway rifle as a standalone device, it is essential to learn the correct method of doing a tongue-chin lift. The practitioner must insert their thumb deeply into the oropharynx and grasp the tongue with his thumb and his chin with his fingers. He will then lift the tongue and chin upwards. This maneuver lifts the epiglottis from the posterior oropharynx, allowing visualization of the larynx and vocal cords. The use of a gauze 4x4 may be helpful in allowing the practitioner to grasp the tongue when doing this maneuver. I'm going to demonstrate the importance of a proper tongue-chin lift. In this view, we're visualizing the epiglottis up against the posterior oropharynx, virtually obliterating the view of the vocal cords. The same area with a proper chin lift opens the area directly to be visualized and the vocal cords pop into view. Again, no chin lift, only visualizing the posterior oropharynx and the epiglottis. With a chin lift, good visualization of the vocal cords, the retinoid cartilages, and you're able to intubate. Incorrect technique, inserting the scope too deep and having a completely whited out or pink screen. If you see this, you need to back up, clean the tip of the scope, do a proper tongue-chin lift, identify structures, and advance to the vocal cords.